Welcome back. We're going to spend the second segment talking about asymmetric information and also touch a little on imperfect agency. And if you remember from your days in maybe taking finance classes, taking risk management classes, you were always taught that information turns uncertainty into risk. And risk is somewhat manageable depending on the amount of information that you can incorporate into your decision-making process. And at that point, it'll give you at least a higher probability of being able to mitigate risk. And where we're talking about asymmetric information, it goes all the way back to just to the basics. And it impacts everybody in the healthcare space. It impacts consumers and impacts the providers, impacts payers. It impacts everybody because of the uncertainty. And if you remember Ara's article, he talked about uncertainty and in medical care. And even in the late 50s, early 60s, Ara definitely understood the risk associated with uncertainty within the medical care space, at least. And I don't think that's changed over time. We've gotten better. And when I say we, our ability to understand the information that's needed, our ability to incorporate information into our decision-making processes, and most of the work, whether it's on the provider side or whether it's on the payer side. On the payer side, it's usually information is collected and assimilated and put into spreadsheets, and it's usually analysts, whether financial analysts, economists, actuaries, those type of individuals. On the provider side, it's similar. Especially in your larger groups, they have some economists that are doing the work for them. If they don't have actuaries or can't rationalize hiring actuaries, they're going to farm it out, or they'll buy actuarial services from a large actuarial firm. So everybody is trying to drive information, and with technology, at least the exponential leaps in technology, it's making it easier for both providers, payers, and the consuming public to grab this information so that it helps those types of entities do a better job of analyzing, explaining, forecasting, predicting, prescribing, everything that we use information from a strategic point of view within the healthcare realm. And then Ara especially talked about, and Dewar tag teams or kind of follows on with his line of thinking, uncertainty drives healthcare markets, diagnosis, treatments, and effectiveness. And if you just stop and think about that, I go in to see my medical provider. And so we go back to, I talked about going to see my primary care doc. I go in to see the individual, and standing in that individual, my physician, is asking me questions. How do you feel? When did this start? What are the symptoms? He may, look at my nose, look at my ears, look at my throat, listen to my heart, thumps on your chest, takes out that little rubber hammer and taps on your knee to see if you've got the reflexes, which I've never understood the little rubber hammer, but I can understand everything else he does. But the little rubber hammer, it seems like it's almost like a prop that they use. But he is trying, or she, depending on who you use as a primary care doc, they're trying to diagnose what you have. And they are going to use all of the knowledge that they gained from medical school, internship, residency, the expertise they've gained since they've been out in the workforce to try to determine what your diagnosis is. Once they determine that diagnosis, then at that point, they set up your treatment plan. your treatment plan could be some referrals to some specialists. Maybe you're having trouble breathing and you're congested, and so your physician decides, well, maybe you have an allergy, and refer you to an allergist, or if you didn't have your tonsils taken out, maybe refers you to an ENT, especially if you're a child, you're referred to see if you need a tonsillectomy. And so referring you to different specialists, may send you to get some lab work, may send you for some x-rays. If they think you have pneumonia, they may want a chest x-ray just to make sure, but they're trying to determine that diagnosis so they can establish this treatment plan. Treatment plan being, do they give you a regimen of pharmaceuticals? Do they set it up so that, okay, today is, I don't know, today's Wednesday. If you're not better by Friday morning, I want you to come back to see me, and I'll make sure I get you in. So that's kind of the treatment plan that they're trying to establish. And then lastly, it's the effectiveness of this treatment plan. And typically, especially if they put you on antibiotics, if you read the information out on the internet, talk to your physician, you start taking antibiotics, it's usually 48 hours to 72 hours before they really start kicking in, then can really do any good. Now, if they give you antibiotics intravenously, it's a whole different story. But so you're looking at that as antibiotics, and they'll also tell you, well, you've got a really bad cold and you're running a fever, and if it's a bacterial infection, the antibiotics should help. If it's a virus, they're not going to help anyway. So they give you the antibiotics anyway. And to me, it's if I take amoxicillin, it's, I don't know, $5 a pop or something. So I go down, spend my $5, get my amoxicillin, usually a 10 to 14 day supply, and I take it, and hopefully I'm better off. But it's a situation where, and again, it goes back to the uncertainty and the asymmetric information. It's a situation where neither the patient nor the doctor has complete information, leading to unmet needs. It's usually one-sided because, at least in Dwar's case, and to some extent Era, the patient lacks medical training and knowledge. And to a certain extent, that's correct. However, I've been in healthcare for 30-some years, working in the healthcare environment on the payer side for the most part. I have worked in some hospitals, Ohio State University Hospital, and then as a consultant on some hospitals now. So I'm doing some work on have done some work and doing some work on the provider side, but it's not just the providers have the upper hand because, again, undergraduate degree, medical school, residency, internship, expertise as a physician or as a provider. So they do have, it's more of a one-sided in most cases. However, patients in a doctor's office are not maybe the most forthcoming. If you remember the last time, I can tell you the last time I went for my physical, and I'm sitting there, and the girls, the medical, I guess the medical tech is going through the questions for me. Do you smoke? Well, no, I don't smoke. Do you use any other tobacco products? No, I don't use tobacco products. I don't vape. I don't do any of that stuff. Do you consume alcohol? Yes, more of a social drinker, but yes, I consume alcohol. Do you exercise? Well, no, I don't exercise. I mean, going through all of these questions, and if you honestly answer the questions, it gives the physician a better idea of what your health status should be. But I know individuals, and we've discussed it in the past with among friends or among coworkers, that they just make up stuff when they go in to tell the physician because they're afraid they'll give them the wrong answer. They don't want to be truthful about it. So there is some issue, and especially if you're hurt at work, because if you're hurt at work, then what happens? It ends up going to workers' comp as opposed to being covered under your medical care benefit of your health benefit plan. So, in a lot of doctors' offices anymore, one of the first questions that they ask it'll say on, on when you're filling out the little tick sheet, or even on if you're doing electronically, it will ask, or there'll be a question in there that says, were you hurt at work? I may have been hurt at work, but I don't want the physician to know, because I don't want it to go back to workers' comp. I want it to go to my medical benefit on my health plan. So there's just a lot of asymmetric information floating around out there. And because of that, it makes diagnosis difficult. It makes establishing a treatment plan difficult. And you hope it doesn't negatively impact the effectiveness of that treatment plan. And with that in mind, and again, individuals, so it's the individuals go to the doctor's office. They may not be forthcoming. You've got the doctor sitting over there trying to figure out what's going on and diagnose what's going on. And to me, the worst thing that any patient can do when they're seeking healthcare is to take whatever the healthcare provider tells you as the gospel truth. I always believe in questioning everything, every piece of information that I get out of a doctor's office. I'm sitting there, I'm taking notes, I'm writing stuff down, because I'm going to go back home and I'm going to start looking things up on the computer. I'm going to go to WebMD. I'm going to go to some other website that talks about medical care. I'm going to look at my PDR, my physician's desk reference, to look up information on the drug. Should I take it? Should I not be taking it? So I'm taking the information I get from the doctor's office, and it may just be that I've been in healthcare for so long, I'm just a little leery of all of the information I get from a healthcare provider. So that's what I'm going to do. Now, the majority of the individuals that go to the doctor's office, they come out and say, well, Dr. Smith told me this, and it's got to be true, because he is a physician and Dr. Smith knows. And I think that everybody ought to step back and make sure they understand what the provider is telling them, and make sure it makes sense to them. And if they don't, they need to ask questions. And so as we go through the information gathering process and understand asymmetric information actually becomes an economic good, because it mitigates ignorance, as long as, and it's going to be something that people will try to grasp or get their arms around, try to collect as much information as possible, as long as what? As long as the marginal benefit is greater than or equal to the marginal cost. That applies value to information, especially healthcare information, and it associates a cost to that healthcare information. That cost, for the most part, is going to be the time you spend trying to identify information, trying to collect information. Now, some individuals typically just say, well, we don't care. We're not going to waste our time on the internet. It's just not going to happen. I don't have that kind of time during the day to try to ferret out information talking about my healthcare diagnosis, treatment plan, what I think the effectiveness is going to be. I'm going to spend my time watching ESPN. I'm going to spend my time watching some soap opera, or I'm going to spend my time, I don't know what people watch during the day on TV, but I'm sure they do watch something. And at that point, they'd rather spend their time doing that than to try to ferret out information that's going to help them make objective decisions about not only their health status, but objective decisions about the medical care that they are going to either seek or receive, and healthcare in general. And individuals that don't do that, I've always considered them, to be selective ignorant, because they have the opportunity to gain the knowledge and to collect the information, but they decide not to. And then when you go to see your doctor, the doctor's going to drive the treatment plan, at least for most people. If I go and talk to my physician's not going to be driving the treatment plan by themselves, because I'm going to have input in the treatment plan. My wife's worked in healthcare. She's a healthcare consultant also, and she's definitely going to drive her treatment plan. Both of us, from a clinical perspective, know enough to be really dangerous, but I guess at the same time, we know we have a pretty good idea of where to go get the information or pick up the phone and call. We have enough contacts in the healthcare arena that we can pick up the phone and call them and say, this is the treatment plan I received from my doctor's office. Are you sure that this doesn't make sense to me? What do you think? So we have alternative ways of gaining the information. But when you look at the doctor-patient relationship, it's typically a principal-agent problem. So I'm the principal. I'm the consumer. It's no different than going to see my State Farm agent. I mean, my State Farm agent and I have a principal-agent relationship. But with my doctor's office, it's a principal-agent relationship. And the perfect agent, if my physician is the perfect agent in our relationship, they will make decisions consistent with principal expectations, my expectations. Imperfect agents persuade principal. So my doctor persuades me as the principal to accept decisions based on the agent's self-interest. And there's where we get into what's called SID. And it's called supplier-induced demand. So remember, SID, just the acronym, is supplier-induced demand. And that is similar to, I'll give you another example. Another example of supplier-induced demand might be, and especially on the asymmetrical information side, might be when you go into your local car dealer and you're looking at a used car. Okay, a lot of car dealerships now have certified pre-owned, they do a bazillion and one checks on your used car and they'll guarantee it for 2 years or something. You've got Carfax, you've got CarMax, you've got, all of these outfits that you can go and at least have a principal agent relationship with. But when you go into your local car dealership, you don't know how much induced demand is going to be incurred in there, because you may not, even though you've been out on the internet and you've collected a lot of information, you may not have the full picture. And so it may not, physicians aren't going to be happy with me, making that comparison, but it is a similar comparison. They have the knowledge, the agent, the doctor, the physician has the knowledge, the principal, the consumer, is going to have a lesser level or a lesser magnitude of knowledge and may not be as accurate as your physician's knowledge. And so you can end up in a situation with SID, again, supplier-induced demand. And a great example of it is multi-specialty group where they've got primary care docs, they've got ENTs, they've got orthopods, they've got cardiologists, they've got, every specialty under the sun that you can think about. And you're going to see your primary care doc, and unbeknownst to you, the principal or the consumer, depending on how you want to look at it, there is a financial relationship that covers the entire multi-specialty group that could involve a financial arrangement where it is in the primary care doctor's best interest financially to refer a lot of services, to specialists within the multi-specialty group. You can get the same thing with the smaller group where you've got 2 or 3 physicians, they've gone in and they've got a partnership, and, LabCorp comes in and says, if you put a, lab service in your doctor's office, it's going to increase your, revenue by X number of dollars, because now, with a LabCorp lab in your office here, we can, we'll provide a phlebotomist or a lab tech, and they'll draw the blood, and we'll run, and you can bill for it, and think of all the money you're going to make in addition. May get the same thing if it's a radiology for X-rays, and maybe it's maybe especially, let's say you're an orthopod, and they come in and they talk you into having being able to sell crutches and inflatable cast and different things. So you've got all of these kind of collateral type, ancillary type services that can boost your revenue. And as a physician, you just have to be careful as a consumer, because once you go into that physician's office, you can talk to the physician, and you'll get an understanding of maybe what the treatment plan is going to be and what the diagnosis is going to be, but you're never going to understand the financial relationships that are in the background that are driving decisions. And that's where it talks about imperfect agent persuades principal to accept decisions based on the agent's self-interest. And again, if you go back to the three pillars of economic thought, you've got margins, making decisions at the margins. You've got opportunity cost, and what's that third one? Acting in a self-interest, optimization, maximizing revenues. Just could be a lot going on in the background. Maybe you're going to physicians, and maybe you actually need the blood test. I don't know. Or maybe you need the X-ray. But I guess I've been in healthcare long enough that I just always in the back of my mind, I'm always wondering about, and again, I'm an economist, and I've worked a lot on the finance side, and I'm just always wondering about what the financial arrangements are that drive that. That's going to pretty much wind it up, I think, on just the asymmetric information side and the imperfect agency. And when I come back, we're going to talk about, for a few minutes, we're going to talk about price elasticity of demand for healthcare goods and services. Talk to you soon.